Welcome. Good morning to everybody. I'm excited about obviously moving from yesterday into today's work, and our panel this morning is a great example of taking a lot of the work and actually implementing it at the community level. And I think that that's a really good way to start the day with a very tangible approach and a very tangible look at how does this get implemented, and in some very exciting new ways across multiple disciplines and multiple areas. So I know that Bill is going to start with some more introductory comments and sort of set the context and frame, and then do some other introductions. So we're just one moment. We're a little bit behind schedule, so we're just going to probably push the schedule, further to accommodate the time, because I don't want to cut the time on the panel here. So thank you very much. Thanks, Bill.
Thanks, Dan. Okay, let me just give you a sense of the order in which we're going to go. As Dan said, and I'll make a few more comments about this in a moment, but we are going to be talking about some models that kind of flow from the discussions we've been engaged in a number of years here, and papers we've presented that really start to focus on innovation emanating from communities, multidisciplinary. So in this instance, we're starting to think and work with groups, nonprofit organizations, government organizations, schools, health, foundations, around the consumer-centered potential, a consumer-centric approach that actually would allow you to start thinking further and moving the ball all the way from birth, preschool, to school, to community college, college to workforce. And we've got some models that we'll be discussing today that are real-time in play, that are doing what Penny mentioned yesterday, as did others, leveraging technologies and making them extensible. So we'll start with the community college discussion, and then Andy with Elisabeth and Ted Levitt in the partnership that they're engaged in, the single-stop model generally in terms of how they're going at the issue of benefit coordination and trying to really hit the question of can we increase retention in community colleges with a benefit coordination model, and as a result of that, increase the graduation rate at the colleges. This is a giant question that really both sides of the political aisles have reached some consensus on. Big-time foundations, including the Gates Foundation, has been publishing a lot and really honing in on, and the Obama administration is. So the model of what Single Step in Miami-Dade we'll be talking about. And then we'll also talk about, and Andy Brickman will talk about models that have become extensible that are, in some ways, the technology is originating in health, tied to some of the ARIS stuff, the Regional Extension Center, Health Information Exchange, HRSA funding, the developments around managed care and Medicaid in the Medicaid marketplace. A lot of the technologies in Miami that are coming together on those sides, because of partnerships with health and education, they're now doing extensibility using the same technology in education. So we've got some pretty interesting models coming there. And then Dolan will come up. Kevin and myself and others have actually been doing some work with many of the federal agencies around service-oriented architecture and cloud, and really building off of what some of the work we've done, but largely the work Rick and CMS did on MIDA, and thinking out, just talking and thinking out where the technology is going to go. And so we'll get a little deeper on the technology at the end that'll basically explain how this can work from a technology point of view, but the focus primarily being the business side of the discussion in the beginning. So I'm going to make just a few introductory comments. We had talked a year ago after some meetings with a bunch of governors and when the economy flipped in a negative way about kind of three themes in that they're tied under a title of urgency to innovation. But the basic argument being that change occurs in a crisis, and there's truly a crisis on the economy that really started to play in 2008 to 2009. Prior to that, we had a number of trends towards connected systems of care, much of what Dan has talked about in his intro remarks earlier. We had some converging markets that tied to the financial meltdown, and then the emphasis upon much of the financial meltdown in the country in terms of trending it out, as everybody says, is tied to what the hell are we doing with health spending in the country. And so you start to see the interface of economic development, healthcare, and, for instance, education, because they're all tied together right now. And so those themes start to generate opportunities to think about shared services and how we can connect information and services and system delivery reforms, and then development of innovations. This is something that came out of right after when the economy blew, and then ARA and some of the high-tech type funding came out. We actually had invitations from probably 5 or 6 governors around the country to come in and start to basically do some brainstorming around how they were going to deal with both budget, leverage policy issues that were occurring at the federal level, rethink the order in which how they organize their health and human service systems, and also rethink the order in which they built, rebuilt, modified, extended technology so that they weren't replicating these things. And that put us in meetings we had, for instance, with the health department in New York, Governor Manchin in West Virginia, Governor Riley at the time in Alabama, Governor Schwarzenegger, Wyoming, Governor Friedlander at the time. So we were trying to get out fast and get a handle on the very large states, small states, the urban states, the north, south, east, and west. In about a period of 3 months, we spent 2-day sessions with governors and or their senior executives in 6 parts of the country. And this slide came out of that, particularly the first meeting we did in New York State, because we were just trying to trend the potential opportunity for integration and interoperability in a changing marketplace. And the first part of this slide, and by the way, you can put it's hard for you to see that. Those are just examples of health and human service agencies within the states. Medicaid being in the center, public health, TANF. We would also, in other versions of this, include other services, education, okay? But if you go back 3 years ago, the MIND architecture starts to envision, and much of the talk that was coming out of CMS, and actually an even that was reiterated and emphasized yesterday in Penny's talk, was the idea of leveraging what was occurring in the CMS to Medicaid space and starting to think about making it extensible across agencies. So I didn't have time in the earlier slide to get into this, and Kevin will get into some of it. But the basic theme here being, you can start to have, using a service-oriented approach, develop shared services across systems, whether they're eligibility, whether they're identity management, common client index, rules engines, right? And so that thinking started to articulate out of, in examples of that were much of the work done here and work we've been doing for a number of years on a connected health and human services framework, which is very close to what MIDA was doing as well. But when the stimulus occurred and the economy started to flip, and then the high-tech and the ARA funds came out, you now saw not only the health and human service industry there, but you saw the public sector, federal and state health marketplace coming down to the commercial health marketplace. So we start to talk about CMS, and we start to talk about Medicaid, and we start to talk about medical homes and accountable care organizations and relationships to teaching hospitals and hospitals. Well, what becomes very interesting in this discussion is the opportunity changes, because if you were a governor who didn't really want to own the budget problems attached to healthcare, other than the ones you own on your health side or your big investment, 40% of your budget's health and human services. But now they've got, well, geez, the EHR funding's coming from CMS down to Medicare and Medicaid and out. The insurance exchange funding is coming in combination from CMS down 90% and on the eligibility 100% down. And that can extend into these systems and those systems. So the relevance of this discussion was that all of a sudden the opportunity for service delivery reform starts to play at the interface of these systems in the commercial marketplace and in the public sector marketplace. And you start to see new models, and I'll make a few more comments about that in a moment, but if you put a circle around this, you start to see medical home models and accountable care organization models that will emanate in communities at the interface of hospitals and community providers that can be leveraged in education, or an area that we've been putting some more thinking into in areas like developmental disability. Because if you look at the tracking of the need in the states to generate services from inpatient facilities down to communities, community care models for either developmental disability or mental health, who are also big pieces of Medicaid spend. You have a lot of factors driving in there that would say we can replicate models that we're using that are emanating from health and drive them into developmental disability or drive them into education. Okay, so we're going to get to examples of that type of thinking here in Miami in 1 minute. So some of the emerging themes. The ability to move beyond the debate, health reform to delivery system reform. An awful lot of where you will find consensus, for instance, if you talk to any 10 governors, regardless of party, will be around the fact that they have to improve their economy. They're very concerned about workforce and jobs, and they're very concerned about the cost of maintaining the services in the current models. So system delivery reforms, developing medical home models as opposed to high-cost inpatient settings. Again, you can take that same approach and drive it into a correctional to community model or a mental health, mental retardation model. Driving efficiencies, outcomes, and improving access. Workforce development, health, and education. That theme, we sponsored a forum with Governor Patrick, Governor Beebe, and Governor Douglas in one of our innovation centers in Boston last year. That was the first day of a 2-day national forum with the HIT coordinators and Medicaid directors and others. And it was compelling how the governors started to talk about how do we think of workforce in this context. If you want our attention, think of workforce, economic development, how do we prepare the economy, how do you tie your health thinking to children and education. I mean, that's where the innovation and vision will start to occur because it gets right to the needs that these groups are dealing with. New types of providers and service delivery models. So much of the funding, for instance, in ARA, anticipated the development of new models of delivery and providers of delivery that didn't exist. All right, so the regional extension centers, a lot of the medical home models that will develop, a lot of these entities didn't exist. So you found the convergence of some thinking on the foundation side, nonprofit side, partnerships with nonprofits and colleges, as Elisabeth is doing, partnerships between health and education, as Andy is doing. That type of thing we're seeing a lot of in the country. Case coordination versus case management. The point there being, you're always going to have at a state level anywhere from 20 to 50 different case management systems. The argument starts to turn in. You don't need to wait to dump all of them and come in with some mega model. Using a service-oriented architecture or cloud strategies, you can start to coordinate care across those systems. And then we have other examples of some of those care coordination models: chronic condition management, medical homes, community health centers. Movements that we will see in the next 3 years as the governors and this federal government start to think about flexibility and cost and moving from fee-for-service to back to more managed care models and the development of accountable care organizations from the CMS Innovation Center. You will find opportunities. I had this discussion with Max Chimura recently. You will find opportunities to rethink models of self-sufficiency and funding, again, on the MRDD side that can mirror that thinking, that could leverage the federal Medicaid money, that can leverage community money, that can leverage family investment in the consumer. So we're going to see the convergence of thinking across multiple systems. In fact, we're seeing it already. Emerging models on the technology, we're moving from. Actually, I'm not going to go deep on this. Kevin may get into this because I want to get to the panel, and on the technology side, this could take some time. But we're moving from the concept of interoperability to liquid data that can go into the cloud, be accessible across systems. That's where I referenced the last minute of service delivery, moving towards the cloud. We're looking at community care models, the health centers, school-based medical homes, minute clinics is a number of parts of the country, telehealth. We're seeing models in telehealth evolve where, I mean, you take games like in long-term care settings or where you're providing services to elderly at home. Just the use of technology like Kinect or Xbox with applications that are geared towards rehabilitation that can tie to tie directly to the home and tie directly to a personal health record. We're seeing a lot of that start to generate, both in the U.S. and around the country as people are coming together. And then the innovations at the interface of education, health, and human services. So the focus is around connecting consumers, providers, and community to health and education data, and at the same time thinking of that in the context of enabling economic development, enabling the workforce development, and thinking from the point of view of a consumer-centric model, so that the point is we want to have this person more self-sufficient, and we want to have a strategy that starts with the child and the family, and we have the vision, and this is a broad vision here, although you're going to see some ways that these people are connecting the dots on this, that literally go from birth to the workforce. So with that, I'm going to start with focusing on Single Stop in Miami-Dade on what they're doing together on retention and very focused effort on reducing poverty, okay? And then we're going to go from, and that will include Elisabeth and Ted. Then we're going to go from that into Andy Brickman speaking about the Children's Trust and the efforts of the Children's Trust in Miami and how they're connecting on the health side and the school side together and what they're doing at that arena. And then Kev Dolan will finish in which he'll tie together from a technology perspective how those types of different themes can come together. And with that, I think I'll kick it to Elisabeth.
Good morning. How are you all? First of all, thanks to Bill and Daniel for bringing us all together. I think this is an incredibly exciting time to think across systems and across disciplines to see what we can do to move innovation forward. So I'm happy to be in this room with you and hope that we can generate a conversation that's useful and lasting beyond the fleeting moments we have together. I actually want to start with a really basic show of hands, which you'll see later where I'm going with this. But how many of you have or have had young children? Oh, love it. This is great. So now I have my audience here. So I have young children. I have a 5-year-old and a 7-year-old. And how many of you, during the time that you had young children, were able to read a lot? Exactly. So I used to be a voracious reader. And these days, I only get to a few books a year. And a lot of times, you'll be able to relate to this. I have to pick books that my children, both who are boys, will relate to. So I've been doing, I'm a history major from this school's rival. I don't like Yale, no offense. I mean, it's beautiful, but, and I clearly am not good at science and things like that, even though I'm here talking about a technology thing, and I'll tell you all about it. But I've been reading this book about Darwin because my boys are really into, dinosaurs and things like that. And it's really interesting because when Darwin described his moment of clarity around the theory of evolution, when he sort of said how he came to it, he described it as an aha moment. It was a big revelatory second in time. And many innovations throughout history are described as aha moments. However, when scholars went back and actually have sort of perused his journals for the months and year coming up to this aha moment, what they found is something really interesting, is that repetitively, time and time and time again, the theory of evolution emerges from these pages. So that even though he saw it come to him in a flash, he was talking about it for a year in advance. What's really interesting about this is that, in fact, most innovations aren't just aha moments of one person, but what they are one person looking across different systems or different systems of learning and extracting lessons from one field to another, applying them, and coming up with new ways of thinking about it to get new results by using completely different applications. And so actually what I would say, and I was thinking about this because this is about interoperability, right? And in a broader scale, not just on a technology level, but interoperability about technology and fields, and how can we use these things to change the world or to improve things. And it's really interesting because I think we have to sort of like bring the sexy back to interoperability, right? Because interoperability is about the history of ideas. The history of all innovation is about people looking at what they're doing and extracting ideas from somewhere else, platforming those ideas, redeploying them in new ways, and coming up with new answers. And that's what, in a very, very small way, I want to tell you about what we do and how we do that today. So, single stop, and I've lost my little clicky thing. Oh, see? This is the... Single stop, let me start by saying, which I'll debunk later, I'll tell you what my aha or our aha moment was. There are 20 million American families living below the poverty level. And our aha moment, or what we thought it was that we realized in a flash, we thought, that $65 billion a year, every year, that could go to move these 20 million families out of poverty was going unclaimed. That's pretty shocking. You think about the fact that we're in the greatest economic crisis since probably the Great Depression. And everybody's like, oh, there are no resources. Everybody's crying about resources, quite rightly crying about resources. And shockingly, if you start to look across silos, there's actually tens of billions of dollars out there being inefficiently deployed or not deployed. And if we could only start looking across systems and looking at interoperability, we might actually be able to partially solve the poverty issue with current resources. That's an aha moment. What's interesting about it, of course, is that it really wasn't aha at all. What it was spending a lot of time thinking about all these different systems and how they weren't working and how they could work if they were all to work together in a very different way. The majority of Americans don't access the 4 major benefits, that's including tax credits. These are working Americans in general that they're eligible for. Actually, 97% of Americans that are eligible for these work supports don't access all of them, which means there's a huge, if you think about 97% of the Americans who are eligible for work benefits and work supports don't access them, that's how big the opportunity is. It's a 97% opportunity for change among the working poor. I'm going backwards. Let's do this. We thought a lot about that money and those resources, and we thought, wow, if you look at all that money and those resources, that could be really useful if we brought it all together, sort of de-siloed the child care from the Medicaid, from the tax credit world. We want to sort of break down the silos, break down the barriers, and make these work together, because a lot of the ways that supports are set up for working families in this country just doesn't make any sense. A family is a system, right? A family experiences their healthcare needs along with their food needs, along with their shelter needs. You can't sort of split those things out. And yet the way we respond as a social service sector, as a government to those needs, is by splitting them out. Come here for your housing issues, come here for your healthcare issues. If you have medical issues, come here. Your kids go somewhere else for medical issues. It's all split out. And technology is one way we can start to reintegrate those things to make efficiencies that actually bring better service and, more importantly, better outcomes for families. But the other thing that we were looking at was where could we most efficiently deploy this redeployment? And we wanted to find the quote-unquote lowest hanging fruit in the country in terms of what population was most ripe to be moved from the lowest quintile in poverty to one of the middle. And the answer is it's the community college population. And there's a lot of data behind this, and I'm happy to discuss it afterwards, but it's pretty glaringly clear. Basically, the path out of poverty in this country is still higher education, more so in a knowledge economy. And the lowest income people go to community college, even as a pathway to a 4-year degree. So there are 12 million students enrolled in community colleges every year, and that number is growing dramatically as the recession grows. I mean, it's growing by 20% a year. And those are mostly 12 million future families that will either be in poverty or won't, based on whether or not they complete that education. It's a pretty darn big pot of people to hit. And guess what? They're doing everything right? They've made it out of not great high schools. They've made it into college. They're struggling through. A lot of times they have remedial issues, but you know what? The research shows that they'll struggle through those remedial issues because these are persisters. What happens actually is that more than half of them drop out, and that shockingly, most of the obstacles are financial and family obstacles. It's childcare. It's that they can't, make a choice between fixing their car and paying tuition. It's they can't put food on the table for their kids, so they decide not to buy books. I mean, they're real trade-offs for these people. And those trade-offs are tragedies. They're tragedies for them because it means they're not going to be able to participate in our economy. And it's a tragedy for us because, honestly, community college systems are sort of the engine of the American dream. It's the one core engine left. It is the way that low-income populations, immigrant populations without access to higher education at Yale, let's say, have access to move up the economic ladder. And if that system starts to fail because most people can't get out, because most people can't afford to get through, then we have a real problem around social mobility in this country. So we looked at that and we thought, wow, actually we have a real problem. We also have a real opportunity. What if we can redeploy what is classically known as, or thought as, and it's a misnomer, but I'm just going to use it, the welfare system. What if we can redeploy those untapped quote-unquote welfare dollars, which weren't because they were for working poor? What if we can redeploy those and use those as an expanded form of financial aid, of support for families so that they can stay in school, move up the economic ladder, pay taxes, participate? What if we can bring these systems together and actually move several million families a year out of poverty? So that was the aha, and it was also the slow hunch around interoperability that is what we're doing. And all the research shows that if you even get a year in retention community college, you go up in terms of earnings. There's 40-year labor data supporting this, and it's only going to become more so the case as the knowledge economy pushes down on us and we have international competition on these things. So there are a lot of studies behind this, both that financial interventions make a difference and also that this education leads to increased earnings. Let me tell you very briefly how it works. It's actually sort of interesting, and happy to answer more questions, but we have books and you can look at it and don't want to bore you. Single stop, what we do is we actually go to community colleges, and not we actually fund community colleges, because I actually don't think nonprofits are like change agents in this world beyond the tipping point. So actually our work with community college is all about institutionalization. We don't want to replace what community colleges do in 50 states. We want to be in community colleges in 50 states by actually having the community colleges take up this model of expanding financial aid and services through redeploying these existing resources. So at every single stop site, we have full-time coordinators doing benefits access. We have free tax preparation during tax season. Amazing. We're getting actually about $1,500 cash back, money that people are owed for work that they did on their taxes for community college students, and that's usually at least a semester's worth of payments. I mean, it literally is like night and day. $1,500 cash back for a family income of $12,000 is unbelievable. It is absolutely revolutionary, and it happens in an hour at our tax sites. Legal counseling, we bring in lawyers to work on housing issues and family law issues and other issues that can really keep students from staying in school because they're so overwhelming. And financial counseling. We offer free one-on-one financial counseling, which sounds weird because it's for like poor people, and who counsels poor people around finances? But They actually need it more than anybody else because they're actually the ones who are paying the highest interest, getting ripped off the most, getting sold the worst products, and they need the private one-on-one financial counseling more than anyone to be able to stabilize their families and avoid economic tragedies like eviction because they've gotten, I don't want to use this word, they've been mistreated in some sort of financial intervention. The cool thing about this is Microsoft's CRM and the Benefits Enrollment Network. So what we've done is put this system of human interoperability into this system of great community colleges, drawing down on all these vast resources. And what we've done is simplify it through a Microsoft CRM platform technology called the Benefits Enrollment Network, which we own. We're a for-profit. We're a not-for-profit, poverty-fighting not-for-profit. But we happen to own a private technology company, which is in service purely of what our 501c3 goal is, which is to fight poverty in the U.S. And we use that because it allows us to very quickly train and get out hundreds of thousands of pages of government arcana to our social workers at our sites. I mean, I don't want to train them on every little nuance of every little federal reg. And I mean, you just can't get there that way. This allows people to come in 15 minutes, like TurboTax, do a benefits eligibility screen, get all their information into our system, and then we can filter them out. We can actually do applications online for food stamps. We can put them to our tax credit sites. We can do applications online for Medicaid. We can do all the applications there, and then we can also triage, because it's a case management system, between our lawyers, our financial counselors, and our social workers, and the colleges. It's really actually a pretty extraordinary use of technology to make things work more effectively. On the campuses at Single Stop, you can talk more about this, Ted, right? But where we're located, we embed within the financial aid and student services offices of campuses. And the Single Stop coordinators and Single Stop workers at these campuses are not my employees, they're Ted's employees, and that's really important. We don't want them to be our employees, we want them to be the employees of the college. The Benefits Enrollment Network, which is built on a Microsoft CRM platform, we've had a great partnership with Microsoft around this, is incredible. And anybody who wants to see it is welcome to see it. But basically, it gives you this 15-minute screening, which sort of tells you what you're eligible for across the board very quickly and very clearly. It has incredible functionality in terms of client tracking and evaluation, which for us is really important because we're an impact organization. So somebody wrote an article about outcomes for this book, Daniel, and how outcomes are being misunderstood or understood in this field. And for us, outcomes is impact on our clients and whether we can move them out of poverty through education. The interface is incredible, very typical of Microsoft tools. It's a counselor-facilitated application process with online submission, and it integrates with our existing partners so that they can share information and nest information across users and actually do coordinated case management across different systems. And it provides ongoing training and support, and we can do asset building and corporate benefits and a whole bunch of other things, links to banking. I'm going to skip through some of this just because I want to get to Ted, and I know we're running out of time. Just so you all know, in 2009, we actually have our 2010 numbers, but in 2009, our final numbers were this. We launched in 2007 nationally. So in the last 3 years, let's say, we've grown to serve about 120,000 families a year, so about 500,000 individuals, and drawn down about $300 million in benefits and services. Our ROI is about, in our community college work, is about 20 to 1. So for every dollar we invest, we draw down about 20. And that's social impact as well in terms of looking at graduation rates and increased graduation rates and what those mean in terms of value. So the ROI is like, put me up against anything in the market, not only now but ever, unless Madoff in his completely made up days, but put me up against anything in the market because I think we can beat them. And on something that's much more valuable to do. So the results have been extraordinary. We're really excited. We've to build with our partners around the country. Miami-Dade is an extraordinary institution. Ted will tell you a little bit about it, but it is the largest educational institution in this country with 170,000 students coming from, I don't remember recently how many countries, but it's a lot, speaking almost every language on earth. It is led by a man named Eduardo Padron, who's an extraordinary individual who came to this country as a Peter Pan Cuban refugee as a child, alone. Had to work his way through Little Havana in high school, was told that he wasn't college material, applied to every college he could in the state, and the only place that accepted him was Miami-Dade Community College. He went to Miami-Dade Community College, worked 3 jobs, almost dropped out a number of times because he couldn't really afford to do this. Was also supporting his younger siblings. His parents weren't with them. And ended up graduating, going on getting a PhD, coming back, working his way up, and is now president of the largest educational institution in our country, and probably the go-to person for not only the Obamas, but the Bushes and the Clintons, the last several administrations on higher education policy. He is an extraordinary leader with an extraordinary team. What's more important about that is he is the picture of our community colleges. The Eduardo Padrones of this world are the folks who are going to be left behind, not only for themselves, but for our society. We won't have them contributing these extraordinary abilities if we don't figure out how to do this. So figuring out how to deploy these resources and expand financial aid to move people through higher education is probably the most critical social issue that we're facing in terms of equity in the next generation. And Ted, you'll talk a little bit about how we're doing that in Miami.
Good morning, everyone. Whenever I come to talk about community colleges, I bring Elisabeth. She does all the work. I don't have to do much. But the truth is, it is an extraordinary place. And I'm there 21 years now. And it's populated, as many community colleges are, it's populated by people who, I call them true believers. The passion that goes into wanting to make the place successful, and it's all student-centered. It's all about wanting to make people successful and move them through. And you'll hear in the next 10 minutes or so in what I have to say that there are, extraordinary challenges in what we have to deal with. But I want to back up for a second. Anybody read the op-ed section of the New York Times on Sunday? This is New England. You avoid it, huh? There was an article, sort of a graphic, and it was a map of the country, and it was an assessment of where the saddest and the happiest people are in the country. And it was, in some ways, it was utterly ridiculous. I mean, they were measuring how many times people smile. And, you know how many times people fake smile. So it's a really difficult kind of approach to figure this thing out. But there was down in the bottom right-hand corner, whatever the color was, it was deepest and darkest in the 17th Congressional District, right in the heart of Miami. This was the saddest place in America. Again, probably ridiculous, but it's a good entree, because how many of you have been to Miami? Travel. How many of you have been to South Beach? How many of you have been to Overtown? Not too many. So Miami's not what it appears in the media. Not at all. There's a lot of glitz. There's a lot of glamour. It's South Beach. It's the beach. But Miami actually happens to be the second poorest city in America when measured by median income. And, I've been there living in Miami for 30 years, and I've seen waves and waves of change just since 1980 when I was there. But you go back, Miami has grown up with the college has grown up with the city. If you go back to 1958, there was the revolution in Cuba, and that changed the city dramatically. Then there was Mariel, then there was Guantanamo, and by now, the diversity in Miami is all throughout Latin America. I mean, there's many, many different ethnic and nationalities, and the culture shifts and changes. It's not just the Cuban Miami. It was in the 1960s, but no more. So the city is dramatically poor, and the middle class has disintegrated. There's a study done recently that we were losing 165,000 middle class families, middle class residents a year, and being replaced by poor immigrants who are coming in. So all of that stuff begins to add up, and it has the highest rental, highest mortgage type of thing. This is a city that's really under some pressure. And this is the context from which our students come. And you see the statistics up there, the largest enrollment. We have 8 campuses. We have a number of outreach centers. It is huge, and it is a fundamental commitment to open enrollment. And that means that if you have a high school diploma or a GED, you can come to school, and we will help you get through. And there was just something that happened in Chicago, I think. I don't know that it went through, but there was an effort to insist that students be college ready before they come. And we are saying that if you've got the 2.1 grade point average, if you've got the diploma, you can come. And there's a reason for it. If you look at the city of Miami, if you look at the school system in Miami, and the school system is making some dramatic leaps forward. President Obama was there this past Friday in Central High School, lauding this high school for going from an F school to moving up the ladder. It's hardly an A school, but change is happening, and there's a serious effort. But the truth of the matter is that the graduation rate from the Miami-Dade County Public Schools is around 57%. One of the most shocking figures that you'll find in the country is that the 50 largest metro regions in the country, 50 largest cities and the surrounding areas, the graduation rate is 51%. So you tell me how communities are going to survive that. In Miami, if you take the 57%, it's 60%. 2/3 of those graduates will go to school. So what it comes back to is in excess of 60% of the kids coming out of the public school system, the 4th largest school system in the country, 60% or more are on the street with no credential, nothing. And what's going to happen? I mean, the community is going nowhere. So our door is open, and we know the challenges. I mean, we're drawing students who are top students who are coming into an honors college and then moving on to places like this. And throughout the Ivy League, University of Michigan, we have 70 different articulation agreements with schools around the country, but I'll get to that. It will keep coming. You see the bottom statistics, 7 out of 10 graduates of the school system who move on to colleges or university, they go with us. So it keeps moving. I had thought not to show you this because I didn't want to waste time. We're talking about a partnership with Single Stop, but this is just to give you an idea of what kind of influence an institution like this can have in the community. From the workforce programs to the baccalaureate programs, something like 67% of our students are AA. That means that they're going to finish 2 years of school and they're going to move on to what you could call a senior institution and finish their degree. The professional schools are, in most cases, they are finished after 2 years and they're into the workforce. And that's the AS degree. That AS degree is earning more for people entering the workforce than 4-year degrees at the state universities. It evens out, and the 4-year degree will earn more in the end. But right out the door, $40,000 is the average income for people finishing 2 years of school. And then you have all of these certificate programs that run for 6 months to 12 months, and students are getting a chance to get in. The comprehensive nature of a community college is, in a real sense, what the country needs. Because as far as I'm concerned, this is an era of remediation. In education, there is absolutely no question about it. If you look at all the statistical, all the research studies, since 1970, education in this country has gone down. You can look at every single state budget, every one, and I've studied it, every single state budget. The biggest discretionary item in the budget is education. It's been getting killed since 1970. Our funding has gone down 19% per full-time equivalent student, 19% in the last 4 years. So there's a struggle going on, but I brought this slide up here so you could see that there's so many different avenues into the workforce, into possibility for students. 46% of students in American higher education now are at community colleges. A little known fact, but true nonetheless. So this is a slide. These are the challenges. This is what we're working with. This is what we're dealing with. And the one that jumps out is 46% of the students are living in poverty, 67% are low income, and for us that's 150% of poverty. The latest statistics, which many of you probably know, are that for a family of four, $22,501 for a family of four means you're not poor. I mean, these standards were set up in the Johnson administration, and I think upwards of 7 or 8 times Congress has tried to reform them, but it's never happened. So we're looking at, this is sort of a conglomerate. All of this stuff, if we could have put it into some kind of circular interactive thing, maybe poverty would be at the middle, and you've got, you know, the first time in college, and somebody's coming from a different country, and most of our students, close to 80% of our students, actually it's down, 72% work now. It used to be 80% 2 years ago when there were more jobs. And that 46% poverty, 2 years ago it was 39%. So the economy has had a huge impact on our student body and on the community. So the main point that I want to make, and it's not new news, and it's not something that you're not aware of coming from the places that you do, is that poverty and its effect, poverty is not a line on a financial ledger only. It's not the distinguishing mark, but it's a consciousness. It's a set of attitudes. It's a set of beliefs, not only about oneself, but beliefs about what's possible in the world, about what I can do and what I can't do. And so Elisabeth talks about, about Single Stop being an anti-poverty agency. Miami-Dade College is anti-poverty. And so the linkage and the connection between the two institutions is a natural. It was from the first time that we sat down together, it worked. She and Dr. Padron were hugging each other by the end of the meeting. So one of the things that happens, I said that poverty is an attitude. We deal on our end as a type of institution that we are. We have 74% of our students come in underprepared, but part of their problem is not just the academic deficiencies, but it's the non-cognitive stuff. It's that they've never been in a really rigorous academic environment. They don't know how to study. They don't know how to deal with the stress. They don't know how to deal with the delayed gratification of studying and moving through the difficult times. And, you know, the center of gravity, is it them or is the problem out there? Are they accountable for what's happening, or is it all these problems that are surrounding me? So we need to be conscious of those things. And, you know, it comes down to a lot of students dealing with the fear that they're just not good enough. So if we don't deal with the non-cognitive stuff, if we don't have advisors and counselors and faculty who are awake to this stuff, they fail. it's foolishness on our part to just look at them as, entrance into academia. But they're moving through their own life in our context, and we have to be conscious of it, and it takes a great deal of our energy to do it. But the parallel that I want to make is that the people who walk into the single-stop offices have that same kind of non-cognitive stuff. It's not just the case of, do I get these benefits or not? It's, do I even think I'm eligible or worthy, or am I going to screw up my immigration status? There are lots of bogus beliefs that kind of guide people. And that's why the $65 billion stays on the table, because people come in with a lack of awareness. I mean, we talk about non-cognitive on the academic side, but it's a lack of awareness of what these possibilities are for me and how eligible I am. I mean, I can talk to you about one example after the next, but one interesting one, one of the lead counselor at the Wolfson campus, the downtown campus, she talked about how she was sure it was a single-stop trick, but she has a bowl of candy on her desk, and she offers it to all the students who come in. Would you like a piece of candy? And this one young woman says to her, oh, I would love candy. I would love to have some candy, but my teeth have been killing me for a year. She said, I can't even deal with sugar. And one after the next, people kept saying this. And the beauty of the benefits enrollment network of Ben is that we can start to engage, we can start to put questions in there. Do you have dental insurance? And the point being that a couple of questions about what's your income status? Do you live with your parents? And suddenly you're learning about the stability of the family, you're learning about their immigration status, you're learning things that, we had dealt. Before we met Elisabeth, we were talking with a company that was offering us a platform to do the same thing on a self-serve basis. There was no model of having a center at the college, but it was all self-serve. Just fill in the data. Oh, you could do it with your students when they register online. But it won't happen. They're not ready for it. A lot of our students are simply not independent learners yet. Many of the honors college students and the baccalaureate students, they're doing great. But a lot of our students, the 74% that come in needing developmental help, they're not going to do it. And they're too intimidated by the fact that they might lose their immigration status. So sitting down with Jen or the other coordinators and finding out all of this information. Another example, a family came in, 2 questions, and it was clear that this family was up the creek. The mother was ill, couldn't work. The older sister had emotional difficulties. In the course of 30 minutes in that office, Ben spit out that they were eligible for $600 a month in food stamps, and that in the course of the next month, the sister was on Social Security disability. They had $15,000 extra dollars in the course of that interview. We had a program called Dream Keepers until the money ran out, because we swallowed it quick. It was $300, $400, $500 emergency money just in case the car breaks down or you have a health care emergency. And it kept kids and families in school. It made all the difference. Now we're talking about $3,000, $4,000, $12,000 a year, which, if you're making a family of 4 with 18, means the world. And you can get through school. So I can feel, Bill, we've got to stop. Thank you all. It was very good to have a chance to talk about this.
Thank you, Ted. Actually, in your primer, Elisabeth and I wrote a paper on this theme. I think a key takeaway, though, here, this is a very focused, measurable strategy with a dramatic vision that encompasses not only the thought leaders, but the actual practitioners in the largest education systems in the country. And we're talking about consumers that desperately are trying to succeed. And we're talking about leveraging resources that exist rather than create new resources, and leveraging new service delivery models with technology innovation. So Pretty impressive stuff, I think. I want to kick this now to Andy Brickman. Andy's going to talk about the Children's Trust and the relationship of community health and children at the earlier age of the spectrum through school. And then we're going to be tight on time, but I'm going to have Kev Dolan wrap up with some common technology themes. Okay, Andy.
How much time do I have?
I'd say about 12 minutes.
12 minutes, okay. A couple of weeks ago, the word interoperability wasn't in my vocabulary. Yet, I feel that I was inexorably drawn to this day. And so what I want to do in my 12 minutes, now 11 and a half, is to give you a story of what's happened in the last 14 months and show you how a bunch of vectors that we work on really came together to do this and why this is really the solution that we've been seeking. So the Children's Trust is created by a county resolution in 2002 and was reauthorized by the voters with 86% of the electorate coming out and voting for us 2 years ago. We have about $100 million a year that we spend to improve the lives of children and families in Dade County, and that money comes from property taxes. And we fund a variety of programs, mostly clustered into early childhood, quality rating improvement systems, child care consultation, home visitation programs. We fund a lot of after-school summer camp programs, transition into adulthood for foster kids, et cetera. In the health area, we have, this is, as was said before, we're the fourth largest school district in the country, and we fund 131 health suites, which are suites staffed by a health tech, a nurse, an RN, or an ARMP, and in 305 schools in the county, so almost half of the schools. And therein is the beginning of the story, because we began to build out the concept of a virtual medical home. So this would mean that kids coming into the health suite would have medical records that could be seen in their safety net clinics. The safety nets being the federally qualified health centers, Jackson Memorial Hospital, which is the public clinic, and some of the other community hospitals. University of Miami is involved in Miami Children's Hospital. So we developed a very close partnership with HCN, which is the lead agency for the FQHCs. And in January of 2010, they received $9 million in ARRA funding to build out a regional extension center. So as the HIE, the Health Information Exchange, this HIE, started to be built out, we realized there was an opportunity, and that was the beginning of the story. And we asked the question, using that infrastructure without putting in any additional money, could we send educational information down the pipeline? And so I called together some of the lead pediatricians, educators in the community, some others, and I started to ask them very naively, I asked the pediatricians, would you like to see educational information in your office? And what would you like to see? They got very excited, and they say, well, I'd like to see an IEP. I'd like to see the individual education plan. Or I'd like to see conduct grades. Or I'd like to see disruptive behavior, or just simply grades. Why? Because a parent brings in a child with a presenting complaint of detachment, or inability to concentrate in class, and to make a diagnosis of ADHD, I need to be able to do that in 3 domains. We don't have the data. Teachers are saying we don't know about chronic illnesses. We don't know about allergies. VPK pre-kindergarten teachers and kindergarten teachers are saying, I got a little kid here. I don't know if I'm looking at a child who is just small, or a child who is developmentally delayed, or a child who is premature. By the way, what is the strongest predictor of success in kindergarten? It's birth month. And which birth month will predict the highest grades in early learning? September. Because the kids who are born in September are a year older than the kids who are born in August. So now imagine a kid who's born at 24 weeks gestation, who's even 4 months younger, and you'll see the problem, and it's amazing that they don't have that information. So these leverage opportunities have been guided by the results we seek. We want children to be ready for school. We want children to succeed in school. We want children to succeed in society. And you've just heard a very compelling argument why, if children do not graduate from high school, and in Dade County they are not graduating from high school, or if they don't go on to secondary education, they're really condemned. And so now we envision, and I'm moving as quickly as I can because I know I have limited time, but we see a three-legged stool that is totally interdependent. And the three legs are health, education, and economic stability. And at the beginning, my portfolio started out being health because I'm a healthcare provider and I was hired. But then over time, these other things have been coming under my guidance, and it's a good thing because I'm beginning to see the world a little bit differently. So let's see how they're interdependent. Interestingly enough, people often talk about immunization and other predictors of health care, but what is the strongest predictor of health outcomes? If you load these things, for those of you who are statistically minded, and you load them into a regression equation and you see what has the most explained variance, what always pops out and knocks everything else out of the water is poverty. Poor children die sooner. Life expectancy is totally a function. You put the correlation up on a regression line, and you look at the correlation, and rich people live longer. And the biggest way to die soon is to be poor. When I approach the school system and I talk about health, I don't tell them that it's the right thing to do to immunize children. I always talk in terms of their educational mission. So vision screening, hearing screening, mental health are all critical for children to succeed in school. And by the way, when we look at the symptom presentations in schools, what do we see in terms of, after first aid, the most common cluster of symptoms that we see are psychosomatic complaints. So we have stress-related disorders in schools. These children who are living in poverty are under a tremendous amount of stress. So I want to paint a picture for you of, let's just dream for a second and take this operability stuff and see what we think is possible. One of the things I began searching for just very recently, all of this has happened in the last year, so I want to give you a sense of how quickly this is evolving. But once we have the data sources coming in, and Kevin is going to share that with you and how these pipelines are coming into place, we can see a developmental continuum from birth, actually even from the prenatal period, going up until an individual begins to pay taxes. They've entered the labor force. And there are benchmarks all along that vertically integrated continuum. So what might those benchmarks be? So clearly birth weight and gestation period, whether the child attends a quality preschool, whether the child is read to regularly by their parents, what are their pre-literacy, things like the dibbles, scores going into kindergarten, can they recognize letters? And then once they're in K through 12, there are assessments 3 times a year in K through 12. In Florida, it's called the FAIR. But these data are not shared with anybody. They go off to DOE and they go into the silo and nobody sees them. So imagine if we were to have this, if you will, a thermometer saying this is where your child is, and this is their potential. And we could show that to parents. The one group that we tend to leave out, we talked a lot yesterday about case managers. Well, who is the ultimate case manager for a child? It's their parent. And their parents have, face a number of problems. One, they don't understand a very complex system, and that's why Elisabeth and Ted shared with you how important it is not to just sit somebody down in front of a screen, but to work closely with them. But they don't understand the parent. They don't understand the implications of quality child care, what will happen to their child if they, in fact, haven't had the kind of preliminary education that they need in the home in order for them to succeed in school. It is astounding that by kindergarten we can predict with fairly good accuracy if a child is going to graduate from high school. If a child is not reading by 4th grade, game over. Because in 4th grade, there's a transition from learning to read to reading to learn. In 4th grade, any learning that's going to go on from that point forward assumes that the child will be able to abstract information out of the textbook. So the future of these kids is set by the time they're 6 or 7 years old. Yet the information and the guideposts to say this child has gone off the rails is not available. So one of the reasons we're so excited about Single Stop is that if you try to engage parents to get health insurance for their kids, and we spend about $900,000 a year in that kind of outreach, they don't come in. Those of you in the audience who may have had a few courses in medical anthropology will understand the concepts of health belief systems. And for people coming out of the Caribbean and Central America, they don't recognize that there may be an illness unless there's a symptom. So when HIV started to emerge in Florida, it was impossible to get individuals to stay on their their antiviral regimens because they didn't have symptoms. So parents have used the emergency room as their de facto medical home, and we can't get them to come in and sign up their kids for SCHIP, for kid care in Florida. But they do come in if there's financial assistance, and at the same time that we're putting money in their pockets, we can simultaneously be saying to them, do you know that your child is eligible for Medicaid? 60% of the children in Miami-Dade County Public Schools are eligible for Medicaid, or they're eligible for SCHIP, and there's a lot we can do for you. So that's my story. I think when we talk about client-centric systems, I think the ultimate client for children are parents. They need to be empowered. I think that interoperability, see, I can't even pronounce it, holds the solution for empowering parents. Thank you.
Thank you, Andy. And we're going to close with Kev Dolan. One point I want to make about this that Kevin will emphasize, the technology that Andy's leveraging actually originated, as he referenced, as a stream of funding and infrastructure development on the health side, which was then made extensible to the education side.
Okay, thank you. Well, while I'm wrapping this up, I wanted to thank Dan and Stewards of Change. The inspiration for all that you've just heard came from Interoptimability, the conference 2 years ago, across over in the GM room. So thank you. And I also want to thank Cheryl Kasnoff, who was at HRSA at the time when she vectored me towards Kevin Kearns and South Beach and the project that we have down there. So thank you for that. That's why we're here. This stool is stole from the words you just heard about the 3 tenets of what produces a full potential. Microsoft's mission is about helping people reach their full potential. That's simple. And these 3 things I've been told are the key elements to doing that: having economic stability, good health of mind and body, and having education. So that's the intent here. The pieces that are critical for this and just textual are connecting, correlating, integrating, coordinating, and analyzing. You've heard those throughout the themes of interoptimability and throughout the 5 years of this conference. Consumer-centered, connected is important. This initiative has been done also with public, private, foundation, and nonprofit support. You've seen that here, and all of those are critical to engaging the community. We talked a lot about that yesterday. We also looked at maximizing the funding streams. In tight times, how can you get the most for the dollars of grants and investments from all sectors and put it to work? Thanks also goes to Rick Friedman and the work around MIDA and the work they've done in reusing. You'll see the themes of that throughout the entire project that we worked, the models of using off-the-shelf software and reusable leverage components. And also the themes about flexibility and being able to extend this throughout the community you'll see in Florida, but beyond and across the nation on that. So graphically, it looks somewhat like this. There's a technology that we have that purposely was built and designed to integrate any type of information, not just health information, but from the start, any kind of information you can think about, climactic information, cultural information, anything that could determine and help together predict outcomes and improve health in other areas. So Amalga sits at the core of that. The other key tenet here that was just mentioned by Andrew was engagement of the family. He has taught me, and we've seen through the work in Miami, that the family and has to be engaged or the system breaks down. So purposely from the beginning, everything we've done to work has done that. We begin by connecting the 52 clinics. The Community Health Center Network, Health Choice Network, is in 10 different states operating these community health centers with over 1 million patients. All the schools in in the Miami region, Miami-Dade with 350,000 students, and Andy Brickman's, the Children's Trust Community Health, or the Community Human Service programs are also connected. So purposely from the beginning, that's where we started. The intent is to move this up to the state level and include information from Child and Family Services, from the Medicaid agencies, health and education within the state. Reaching out to the providers, HCN is also the Regional Extension Center covering 3,500 providers for EMR deployment in the state. They're also working on the South Florida Health Information Exchange and working up to the state exchange, and are also connected through the National Association of Community Health Centers to develop the NHIN, and I'll mention that here as well. Beyond the connecting part, it's not just most HIEs, unfortunately, in the country today are in phase 1, where they're just connecting data from patient to, or from the doctor to the patient, the information. But that's essential, and in fact, in some cases, it's saving in Wisconsin $22 per visit into the hospital room. So there's good benefit for that. But it's when you integrate the data that you can begin to transform care. In this particular project, the immediate things is to provide the providers with clinical views of the data that's from all the hospitals and networks that are connected there. But then beyond that, we just announced last month with the feds the release of the NHIN Direct Protocol support. So now we have in Health Vault enabled free email accounts for every Health Vault user, which is free, to be able to get secure messaging from their doctors and providers, and on both sides of that. So the EMR community is working to enrich that, and we're also allowing patients to engage and families to access their health information, and that's being supported by this project. The next piece beyond that is coordinating. It's not good enough just to connect data and to integrate it, but you have to correlate it. You heard some of those discussions yesterday to identify the family and the members of the family and the stakeholders involved in that child's life. So coordination of care, we purposely put this in a cloud. The work with Single Step and the BEN project is all about doing that work in the cloud to make access for the CRM piece there. It's also in working with making this available to the caseworkers and the teachers and the parents so they can all have equal access to this information on a consent level and a secure level. So we call that case coordination. We've developed some new technologies around our Dynamics platform that allows easy navigation and view and predictability and type of analytics on the front page for caseworkers to be able to focus on a family and develop and coordinate care. The new model that Bill mentioned to that is medical home. The ability Prestige Health is a for-profit managed care organization run by and owned by the Health Choice Network. And this particular entity manages 55,000 Medicaid and low-income people. And what they're using is this technology to begin to do managed care from a medical home model. So they have very tight integration. Around that, there are a number of systems that partners have built on the platform: post-discharge information, at-home care, chronic condition management, readmission rate reduction. So there's a number of protocol adherence, an issue that when people leave the hospital, they don't take the right drug. So the Prestige Health is benefiting from this integrated information by being able to coordinate and reach out and directly interface with their people. Now, you can take this is kind of the MITA principle. You use exactly the same technology, the same infrastructure, some different data streams, and you're able to, in red here, light up the capability for the community and the workers in the Human Services Organization with Dr. Brickman to use capabilities around that same model, that case coordination model. Just different use cases, different paradigms, in different places there, but that's also where education can fit in. So that's kind of the coordination piece. And lastly, but most importantly in many regards, is what do you do? What are the outcomes? So there's direct feeds into meaningful use measures, dashboards, visualization, mapping. So all the rich analytics that are capable now become broader, because we don't know, and this came from an autism research scientist we're working with on the project. I asked him, what do you hope to gain from this? And he goes, Kevin, we don't know. We've never had this information all in one place at one time. We don't know what we don't know. We don't know what the core cause and root causes of autism are and how that relates to health and poverty and other economic stabilities, but we're hoping to do that. So we're working very diligently on prescriptive and predictive analytics and work on the other side as well. So that's a quick summary of how that looks pictorially.
Kevin, thank you for that. I'm going to close, Dan. I know we've run late. I just want, and the final point I'd want to make, we're all here to talk. I know we won't have time for Q&A here right now. But I think a very important theme here is one that Elisabeth, Andy, Ted, Kevin all mentioned, which is we're talking about the integration and innovation of service delivery models and technology. The service delivery models, once you start to integrate their approaches, I mean, you heard Andy today talk about the Miami-Dade model and how they're engaging customers and how he can leverage that business model in terms of what he's doing with children, with parents. Similarly, the vision that's come out of this group and has come out of CMS and others, we're able to see that when you put new service deliveries models and you allow the extensibility of the technology, the same approaches, literally technologies, can be bought once and used across multiple systems. And I'll end with this. I think when you think of things like what and we had a brief discussion with Single Stop before we began today. When you think about Penny's comments yesterday about eligibility, and you look at the Navigator program and the whole theme tied to how do we coordinate community care and tie that into what we're doing on Medicaid eligibility and across human services. Think of it in the context we've just talked about. Because it's the final mile here. I mean, you're talking about the ability to now think and put in technology and service integration models that not only tie your Medicaid strategy down across human services, but where you have real live models that have actually started to drive it across health, all the high-tech themes, to the community college and down to the schools and back. So Andy's breaking through the confidentiality stuff because they're literally putting the people in a room and getting consent to do it. And they're sharing education information, deep education information, with deep health information. So I think that's what's exciting. And I think as we start to look at these real-life models where you're using the technology and the service innovation, cross-systems, as Elisabeth said in the beginning on that aha moment, where you're taking cross-system ideas and putting them in use, that's where we're going to take it to the next level. Thank you.